On this video, I'll be talking about how to calculate an axis on the ECG. And then, of course, how we really kind of interpret that in the context of, our patient. So to begin, one of the things when we calculate an axis is really we're assessing hypertrophy or enlargement of the heart. And so one of the reasons, or one of the things that you might find on an ECG is that the chamber takes longer to depolarize. In other words, the ventricles take longer to depolarize, or the atria take longer to depolarize. So that would show up as on an ECG as a longer duration of the wave. So it takes longer for it to depolarize, because ultimately, if you have hypertrophy or a larger amount of tissue, it takes longer. Also, the chambers generate more current, because more tissue means more current. So you would also see a larger amplitude. So this is going to be longer in duration, and also there's going to be an increase in the amplitude. And then the electrical axis, the axis of the heart, can shift due to a larger percentage of current in a new direction. And what that really means is that we have what we call our normal axis, which I talked about in the last video, in the ventricles, which kind of points mostly at, say, right around lead 2 or between lead 2 and lead 1. And that's really, lead 2 and lead 1 are showing where most commonly the average vector, after all of the instantaneous vectors moving through the ventricles have actually completed their course and completely depolarized the ventricle. If we took the average of all of that over that time period, we'd have what we call our mean vector. And that mean vector, or the average vector, generally points towards the left, because the left ventricle has more muscle mass. And when it points towards the left, it points towards those leads that we discussed, which is leads 2 and lead 1. So that's right around 0 degrees and 60 degrees. So if there's a part of the heart that's actually more enlarged, like let's say the right ventricle is enlarged, and there's more tissue there, that actually skews that mean vector, that mean average, more towards the right ventricle. And so the electrical axis shifts towards the right. Now, if the left ventricle is enlarged, that could actually make the mean pull more towards the left. And so the left axis, so it's already pointing towards the left normally, it would be even more leftward. So let's kind of go through some examples and hopefully describe and be able to explain what that all means. So if we want to be able to assess the heart for something like, say, hypertrophy, we're going to want to look at something called an electrical axis. And to assess electrical axis on an ECG, you need to look at the limb leads. So if you recall from the previous video, the limb leads are 1, 2, and 3, AVR, AVL, and AVF. And that's looking at the frontal view, frontal planar view of the heart, which means superior, inferior, medial, and lateral. So now with the axis, what we're talking about is a mean electrical axis. So the atria, when they depolarize, all right, from the time they start to depolarize till the time they finish depolarizing, we're going to take the average of all that electrical activity, and it's going to give us a vector, okay, or an average electrical force. If we take the ventricles, the same thing. From the time it takes to go all the way through the septum to the apex, up the lateral walls, that's going to give us, over that time period, one average electrical force, okay? And so that's, again, averaging all the little electrical forces that have been or instantaneous electrical forces that have been generated through the ventricles. We're just going to average it all together and see where that electrical force is essentially pointing to, in what degree, okay, so what the degree is. So for example, if we just take a look at the ventricles for a second, during depolarization, that's the QRS, so we're looking at the QRSs in the limb leads, and after it's completely depolarized, so the length of the entire QRS, all right, what is the average, okay, electrical current? What direction does it point in, or what leads does it point to primarily? And in general, the average is, generally it points to leads 1, or between leads 1 and 2. So between 0 degrees and 60 degrees, what you'll see is a QRS that has the most upward deflections, or the highest R waves. And so that's telling you that the current is moving, the average current is moving generally between leads 1 and 2 the most, okay? And so that's why they're upright the most. And if you see that the leads 1 and 2, their QRS or their Rs are the highest or the tallest. In general, that just means that this is normal, and you don't have to do any further work. It's a normal axis. So the question is, though, what's the range of the axis? And there's actually quite a big range. Okay, so I told you it's normally between 1 and 2, which is 0 to 60, but the normal range is actually from 90 degrees, which is all the way down by AVF over there, 90 degrees, all the way to negative 30, which is AVL. So let me just point that out over here. So from 90, so that's AVF, to AVL, which is negative 30 degrees. So that's the range. I can actually draw a line here just to illustrate the point there. So that's the range here, is this entire shaded area that I'm shading for you right here. So if the mean electrical axis falls between 90 and negative 30, this is still considered a normal axis. However, if it goes less than or more than a negative 30, I should say, like negative 35 or something, that's left axis deviation, because it's pointing more leftward. If on the other hand it's instead of being 90 degrees, it's say 95 degrees, or moving more towards the quadrant over here, so we're more over in this quadrant here in green, that's right axis deviation. In fact, if it goes all the way to this quadrant over here, which I'm shading in green, that's actually extreme right deviation, not very common. All right. And then over here, this little slice over here, this is our left axis deviation area. All right. So, so to kind of put that in context, if the electrical axis is normally between negative 30 and 90, if it's greater than 90, okay, we consider that right axis deviation, or less than negative 30, so negative 35 or negative 31 or something like that, that's left axis deviation. And with axis, as I kind of alluded to in the slide before this, it's most successfully applied to ventricular hypertrophy, typically. Okay. Again, we might or we will usually do further workup in a patient if we suspect that that's the case. Okay. So I want to take this as an example here. If we take a look at, let me get my pen here. Okay, so if we look at our limb leads, you notice that we're looking only at the limb leads. It's 1, 2, 3, AVR, AVL, and AVF. So when you're assessing axis, you're looking at the limb leads. Okay, and so I'm looking at sort of the QRS complex as a whole. So we're looking at ventricular depolarization. I'm looking at the ventricular axis right now. Okay, so if I take a look at lead 1 and I take a look at lead 2, all right, I see primarily an upright going R, which is good. Okay, you see that upward deflection. However, I told you before that if 1 and 2, under normal circumstances, they should have the most upright deflections. Okay, they should have the tallest R's. But in this case, that's not what's happening here. So if you take a look over here at AVL, 1 is nice and tall, has nice tall R waves, but you notice that AVL's upright deflection is greater than 2, which suggests that there's electrical activity that's moving more towards AVL's direction, the lead AVL, which again, remember that AVL is negative 30 degrees. Okay, is negative 30 degrees. So that's my poor handwriting there, but that's negative 30. Okay, so it's pointing more towards AVL than it is towards 2 because it's more upright in AVL. Okay, now if I want to determine approximately what the actual degree is, I can do that. So what happens is I say here, all right, well, it seems to be pointing more towards AVL than 2. So it's not upright. So this is not a normal axis necessarily. So maybe it's pointing somewhere between 1 and AVL. And if you recall, maybe this might indicate possible left axis deviation because AVL is more lateral. Okay. They said, all right, well, if I wanted to be more precise, how could I do that? Because I don't know if this is left axis deviation or not. I want to be able to calculate this a little bit better. Well, you have to look at the rest of the limb leads. And if you recall from my last video, I said that there's a type of waveform that looks like this. I'm going to draw it over here, where the upright deflection and the downward deflection are about equal in amplitude. And I refer to that as the biphasic wave. Okay. And if it has an upright and a downward going deflection that are equal and opposite there, that actually represents a lead that is perpendicular to that average or that mean vector or that mean electrical force that's moving through the ventricle. Okay, so that means that lead is positioned in a place that is perpendicular to the average electrical force moving through the ventricle. So what you do is you assess the other limb leads to see if there's any that look that it's like they're pretty close to being biphasic. Another term for this, by the way, is isoelectric complex. So there's two terms for that. You say an isoelectric complex. So what you're seeing down here in AVF, it's highlighted in yellow for you. It says isoelectric lead, referring to the fact that this is biphasic. It has an upward and a downward deflection that are equal, approximately equal in amplitude. You could say that 3 is also biphasic. It is biphasic. It's going up and down. It has an upward deflection and a downward deflection. However, there seems to be a greater downward deflection than there is an upward deflection, suggesting that this mean electrical force is moving away from 3 more than it's heading towards it because it has a more prominent downward deflection. But in AVF, you notice that it's about equal. So that means this mean electrical force is moving perpendicular to AVF. So if we look over here at our degrees over in the chart over here, here's AVF at 90, right? And you notice that that's our isoelectric lead. So if that's our isoelectric lead, that means that the mean electrical force could either be moving directly towards 1 or actually moving directly away from 1, because it only tells us that it's 90 degrees to it. It doesn't tell us, towards 1 or away from it. And what you'll notice is that 1 is upright, which means that the electrical force must be moving towards lead 1, not away from it. If it were this one over here, if it were moving away from lead 1, then lead 1 would actually have a downward going, or prominently, a prominent S wave instead, which it doesn't. Instead, it's upright, which means that if this is really our isoelectric complex here at 90 degrees, so 90 degrees to that, it's heading towards 1. 1 is also upright, which coincides with this. There's an upright. That means our electrical axis is 0 degrees. It's 0 degrees. The electrical axis is going directly towards 1, and so therefore it's 90 degrees to AVF. You'll notice that AVL is only 30 degrees away from 1, whereas lead 2 is actually 60 degrees away, so therefore lead 2 upright is a little bit smaller than AVL's, because AVL is actually closer to 1 than lead 2 is, and so therefore that's why you see AVL being a little bit taller. There's no deviation here. This is actually a normal axis. It's 0 degrees. So let's try this on another example. So, the question is, what's the axis here? So let's see if we can do this for ourselves on this ECG. Again, we're looking at limb leads when we're assessing a mean electrical axis. So we're not really going to pay attention right now to any of these over here. All right, those are all chest leads. And then down here, you can take a look at this. All right, that's a rhythm strip. Helps us to assess the rhythm of the heart. So let's pay attention to 1, 2, 3, AVR, AVL, and AVF. All right. So if we take a look, I told you it should be primarily upright in 1 and 2. And if you take a look, 2 is definitely upright, right? But 1 is not, right? 1 is not. In fact, it looks like I see it in here in 3, and I also see it here in AVF, it's upright. Which means that our mean electrical axis is kind of shifted a little bit more towards the right. Okay, again, it might still fall within the normal range, okay, but we have to do a little calculation, because if 1 and 2 are both primarily upright, or the most upright, our job would be done. But since it's not, we got to do a little bit of a little bit more work. So we take a look at 1, 2, and 3. All right, do I see any biphasic waves? Well, if I take a look, I don't have any good clean biphasic waves as I saw in the prior example. But probably not AVR, but if I look over at 1 over here, that's pretty close. Only I would say that that downward deflection is probably greater than the upward deflection over here. It's a tiny upward deflection by comparison. It's fairly close. It's better than AVL, which you notice AVL here is mostly just downward going, which suggests that this mean electrical axis is moving away from AVL. In ones, it's a little closer to biphasic or to our isoelectric complex, but it still has a more downward going wave, suggesting that although it's close to perpendicular, it is not exactly 90 degrees to 1. It's probably a little bit greater than 90 degrees because it's more negative going. So that alone actually tells us a lot of information that this is probably an abnormal axis. So for example, here I'm going to draw out just a couple of degrees there. I know it's not exactly precise here, but here, if this is 1 over here at 0 degrees, this is 90 degrees. Here, this would be our AVF. Okay, and then 2 is over here somewhere. Okay, at 60, and 3 is over here. So our mean electrical axis is somewhere between 2 AVF and 3. All right. If it were directly, I'm going to use a different color here, but if it were exactly 90 degrees from 1, that means it would be either heading towards AVF or away from AVF. But since AVF is upright, that means it is heading towards AVF. It's not exactly 90 degrees. So otherwise, if it were exactly a good isoelectric complex, I would say, yeah, the axis is 90 degrees. But it's not. Instead, it actually has a little bit more of a negative deflection to it, meaning it's slightly heading away from lead 1, which suggests that it's probably slightly pointing more between AVF and 3. Now, that's already greater than 90 degrees, and as I told you, that's out of the normal range there. So that means this is a right axis, because remember, anything over here is considered right axis deviation. So what it looks like is we have a right axis deviation. Now, that's all I'm going to say for that about this right now. I cannot interpret that at this point as being right ventricular hypertrophy, but we need to take other steps in order to assess if that might be the case. So if we see axis deviation, you should definitely be looking into possible hypertrophy. Since this is right axis deviation, that suggests right ventricular hypertrophy. It's not foolproof, so we're going to talk about what are the other requirements in order to kind of be more confident in that assessment. Okay, so let's talk about some of the rules then. If we're going to talk about hypertrophy or enlargement, there are actually some other guidelines that we need to follow when we assess the ECG to make that sort of determination or diagnosis. So here, when we talk about atria, so let's start with the atria. I told you guys from the prior lecture that when we assess the atria, the mean electrical axis in the atria points primarily at lead 2 over here. So primarily points towards lead 2. What I didn't mention yet was that lead V1, all right, so this is a precordial lead, is actually positioned perpendicular to the mean electrical axis going through the atria. So therefore, if we take a look over here at my little cartoon, here's the right atrium. So lead 2 would show us our most upright going P wave, and then V1 would show a biphasic wave because it's perpendicular to it. And that's actually useful for us. So we're going to look at those two leads when assessing the P wave. So the first thing I want to tell you now, or the next thing I want to tell you, is that if you take a look at this box over here to the left, if that's the P wave, you notice that I put a little red dashed line through it. And if you recall anatomically, the sinoatrial node is located in the right atrium. So what happens is when it fires and it starts to conduct through the myocytes in the atria, the right atrium actually depolarizes slightly ahead of the left atrium. Okay, so slightly ahead. So that actually first upward part of the deflection here, okay, which I'm highlighting in green, that actually represents on the P wave, that represents right atrial depolarization. And then the second half of that P wave, that second half of the mound there, that represents left atrial depolarization because the left atrium is just slightly behind the right atrium. So that makes it useful for us when we're trying to determine if the left versus the right atrium have hypertrophy. So for example, let's say the right atrium is enlarged, okay? If the right atrium is enlarged for whatever particular reason, this is our normal over here that I pointed out. So this is normal. Over here, this would be the abnormal, all right, to the right of it. If the right atrium is enlarged, what you'd see is an increase in amplitude. So the P wave would be taller than 2.5 little boxes, all right, so greater than 2.5 millivolts, which I have over here bulleted. Okay, so that'd be greater than 2.5 little boxes. And so that's what you're seeing over here is an increase in the amplitude relative to that guy. Okay. I also want to look at V1 because V1 is the interesting property of having a biphasic wave in V1 is that remembering that the initial part of the P wave here represents primarily the right atrium, and the second half of the P wave primarily represents the left atrium. It's kind of separated the two for me. So the upward deflection kind of represents right atrium, the downward deflection kind of like the left atrium. So that helps. And so what you'd see is an increase in the amplitude of that first half of that biphasic wave representing possible right atrial enlargement. If we look at the left atrium, so this would be the second half of that P wave. This is the normal. So again, I'm looking at 2 in V1. Okay, that's the normal. And then over here, what you'd see is not typically an increase in the amplitude so much as an increase in the duration. So usually with right atrial enlargement, you don't see an increase in duration. With a left atrial enlargement, the duration increases. So this is wider right here. So the duration is larger. Sometimes you can also see what we call a notched P wave. So you see there's a little bump here in the second half of the P wave. That's bumped. Sometimes the amplitude of the left atrium will be a little bit increased. And so it looks like it's got a little bump or a little hump at the second half of the P wave there. And that's referred to as like a notched P wave. It could also be a sign of left atrial enlargement. And then again, we look at V1, look at the biphasic wave, and this first little bump up here, the upward deflection would represent the right atrium, the downward deflection represents the left atrium, and so it's here, it might be a little bit deeper or a little bit more of a downward deflection and wider. And so we look at those two, and then understanding the differences between the left and right side of the P waves, representing either left or right atrium, helps us to kind of figure out what might be going on, and then of course put that into a clinical context. Now, if I'm looking at the ventricles, all right, let's start with the right ventricle. So I'm looking at the limb leads first to look for axis, and I measure the axis, and like in our prior example, this is you need to have right axis deviation. So for right ventricular hypertrophy, right axis deviation is part of the requirement. Then I look at the precordial leads. So if I assess axis and I see that there is right axis deviation, then I'm going to look over at the precordial leads. If we look at the precordial leads, I'm going to look at V1 and V6. So remember, there's the chest leads or the precordial leads go from V1 to V6, and V6 is in the axillary area. V1 is to the right of the sternum, and they're almost opposite each other. So they're going to show typically what we call reciprocal findings. Okay, so if one is going up, the other one goes down, kind of thing. If you recall from my prior lecture, a normal V1, so I'm going to draw a little V1 over here. So let's say this is V1. A normal V1 should have a tiny little R wave and then a much larger S wave, because the electrical axis tends to shift more towards the left and away from V1, which is on the right side. And so that's why we usually see a much larger S wave there, because the electrical axis or the electrical current is moving away from it primarily. And then in V6, we'd usually see the opposite. All right, we see a nice large R, maybe a little bit of an S behind it. Okay, but usually we see a nice tall R wave. So we call that, essentially reciprocal. However, if the right ventricle is hypertrophied, that means that one, we have right axis deviation, okay, and if we look at V1, we have it flipped. V1, the R wave, is larger than the S wave. So that's what you're seeing in this example here. Here you see an R wave, and there's really no S wave here. So the R is definitely bigger than the S, but the R wave is greater than the S. And that's not typical, because I give the example over here. All right, it should typically be a tiny little R and a very large S. So here we have a large R wave, all right, or an R wave greater than the S. And that would make sense because it's pulling the electrical forces more towards the right. So it's facing the V1 more. V6, which again is in the axillary region and would show reciprocal to that, then you would see a larger S wave than an R wave. So it's the opposite of what's normal, right? It's pulling the electrical activity more towards the right, and so therefore away from V6, and so it has a larger S wave than an R wave. So that's essentially our requirement to assess for right ventricular hypertrophy. So let's talk about left ventricular hypertrophy next. So with this, there are actually many criteria for assessing left ventricular hypertrophy, and none of them are perfect. So usually what we say is that the more criteria that it matches, the more likely it is to be left ventricular hypertrophy. But of course, none of this is done in a bubble, and there will be other workup that's done, echoes and whatnot, and things will be put into clinical context as well. But let's just take, for example, out of context, our QRS here, our ECG here, the QRS amplitude, okay, in general with left ventricular hypertrophy, the QRS amplitudes in V5, V6 are usually, the R waves are, usually much higher or much greater. So the amplitudes are usually much greater. And that would make sense because V5 and V6 are already on the left lateral side there. So if there's an increase in electrical activity there, they would be larger. So it's an increase over the normal, which means that V1 and V2, which are essentially opposite those or are reciprocal to those, more towards the right, they would show deeper S waves. All right, so it's really just sort of an increase over the normal. Okay, so to kind of give you more specific criteria, I put 3 bullet points there under that. And so the R wave amplitude in V5 or V6, all right, plus the S wave amplitude in either V1 or V2 has to be greater than 35 millimeters. Now remember, in our ECG example over here, I'm going to draw it in. This is a large box right here that I just outlined in green at the top there. Let me draw a little arrow to make sure you guys saw that. Okay. So that box that I just highlighted there, that represents 5 millimeters. Okay. So if we have 5 millimeters, you can basically count by 5s if you count the big boxes there. So let's take the V5 example over here, and let's just count that. So you can see 1, 2, 3, 4, and it's about 5 boxes, or just about 5 boxes. So we have 5 boxes, and so that's already, 5 times 5 is 25 millimeters right there. Now we take a look at either V1 or V2, and so let's take V1 since that's the one they've chosen here. 1, 2, and just about 3 boxes there. So that would be another 15 millimeters or so. So you're looking at definitely greater than 35 millimeters. So that meets one of the criteria for left ventricular hypertrophy. And again, I just want to emphasize, you can take V5 or V6, all right, measure the R wave and add it to either V1 or V2 S wave. If it's greater than 35 millimeters, that meets one of the criteria. Again, the more criteria it meets, the greater the likelihood that there's left ventricular hypertrophy. So let's take another criteria. So that's the first one. Another one is in the R wave in lead 1 is greater than 15 millimeters. So if we take a look at our lead 1 over here, just kind of eyeballing it right now, that looks to be about 10 or so. So that doesn't meet the criteria. The R wave in AVL, all right, this is our limb lead again. AVL, greater than 11. It's pretty close. I'd say that it's probably closer to about 10 or so. So I would say maybe 10 or 11. It's possible, but I'd have to actually get a caliper out and measure it to be more specific than just eyeballing it. But it looks like it meets at least one of the criteria. And there are actually many, many more, and so you could do other assessments and whatnot, but we'll just use these 3 for now. So the other point I made that it may have left axis deviation. So if you see left axis deviation when you're doing your axis review, take a look at the precordial leads and take a look at those R's and S waves in V1, 2, and 5, and 6, and do the assessment. but it doesn't necessarily mean it's going to have left axis deviation even if there's left ventricular hypertrophy. It may have left atrial hypertrophy. All right, so you can take a look to see if there's any changes in the P waves, and may have T wave inversions and U waves, or in other words, repolarization abnormalities. And this is actually a good thing to keep an eye on, because over here, let's assume for a second that this is left ventricular hypertrophy because it meets this one criteria here. If we take a look at the T waves here, the T waves are all upright. So that's normal. The T waves should be upright normally. So you can have left ventricular hypertrophy with T waves that are upright. Sometimes though, the T waves can be flipped or inverted. And if that's the case, that's often referred to as strain. And it could mean that this hypertrophy is very severe to the point where it's causing repolarization abnormalities. So something you got to keep an eye on. So they usually refer to that as like left ventricular hypertrophy with strain if you see an inverted T wave. And lastly, just to kind of point out this little blue circle that's been circled in the middle there, that's just trying to kind of assess the axis. And if we were to take a look at that axis, see if there's left axis deviation in this case, I see it's upright in 1, okay, and I can see there's an upright, it's upright in 2, but it seems to be more upright in L. So we've seen this pattern before. It doesn't mean there's left axis deviation just yet. And AVF does look like it's our isoelectric complex. It's pretty close, actually. Maybe a little bit more negative going, but overall it looks like this one here is an isoelectric complex. That's pretty close too. All right, so if AVF, that means it's approximately 90 degrees to AVF, and it's upright in 1. So this looks like it's about 0 degrees. So I would say this is probably not, there's no axis deviation in this case. Okay, so here I want you guys, again, before just going through this, you could probably just pause the video, take a few minutes to assess it for yourself before I go through it. But if we take a look, if you're just kind of eyeballing it, you can actually just see that, especially here in the precordial leads. Let's take a look at V5 and 6 for a second here. You notice V5 and 6, I mean, look at the size of this amplitude here. Now, something I want to warn you about, actually, when you guys are, especially practicing in clinic, and I didn't put it here, but you should always check the calibration. I told you from the last video that on average, the normal setting or calibration for this is that one large box, just let me see if I can draw it over here. One large box over here represents 0.5 millivolts, which means 2 large boxes represent 1 millivolt. But sometimes, and you got to check the machines or check the ECG paper, the calibration might have changed so that two large boxes may represent a half a millivolt instead of 1 large box, and so therefore it might actually look like very large R waves, but in fact it's a change in the calibration. So just always check that first. So here, in this case, we're going to assume normal calibration, but you can see these really tall uprights right there in V5 and V6. And if you were to count those boxes again, if it meets that criteria of greater than 35 millimeters in V5 or V6 plus V1 or V2's S wave, and you can see here's V2, you can see these deep S waves, and even this is pretty deep right here. So this here, again, this suggests left ventricular hypertrophy, definitely by that criteria. In fact, if we look at lead 1 from our other criteria, that's about 15, so that meets that criteria. And it looks like not quite 11 in AVL over here, so it doesn't meet that criteria. So it meets at least 2 of the criteria we talked about. And if you take a look closely again at our chest leads, you'll see this down here. I'm going to circle it over here and over here. You can see it in leads V5, V6. In fact, you can see it in almost all the leads over here. All right, but you can see in V5 and V6 you have inverted T waves there. You can see it in AVL and 1, and if you recall, 1, AVL, V5, and V6, what they have in common is that they all look at the left lateral aspect of the left ventricle, and they all have inverted T waves. So it makes sense that they would all kind of show similar findings. And so that definitely suggests that this is left ventricular hypertrophy with strain. Okay. In this section, we'll be talking about arrhythmias, or more accurately, what we should really be referring to as a dysrhythmia. We are going to be using primarily rhythm strips. And so rhythm strips are usually looking at one of the leads, like let's say lead 2, for example, and it gives you a longer duration of the that lead, so that you can better assess the overall rhythm over a greater period of time. And so there are 5 basic types of rhythm. There's the arrhythmias of sinus origin, or from the sinoatrial node. So something that's either going too fast, too slow, or it's irregular. So too fast, something like tachycardia; too slow, bradycardia, and we'll discuss about some of the irregular rhythms as well. Then there's the ectopic rhythms, and so ectopic means it's really a rhythm that's initiated from outside of the SA node. Then there's reentrant arrhythmias. So reentrant arrhythmias is essentially like having electrical current or an electrical racetrack, that the electrical activity is moving around continuously in a particular pattern and firing over and over and over again. Conduction blocks are, as the name describes, is basically a block in the conduction of electrical activity. And so that could be in various places in the heart, and we'll discuss that. And then finally, pre-excitation. Remembering that, when the SA node fires, it travels through the atria to the AV node, and then there's a little bit of a pause. And then from the AV node into the ventricles. And that pause is very important. In some cases, though, the electrical activity from the atria can kind of bypass or move through the AV node more quickly than it should, and we refer to that as pre-excitation. So, there's 4 questions that are good to ask when you're assessing rhythm. So what you want to look at is the P waves. Are there normal P waves present? Okay, we discussed some of the things that could look abnormal, if they're too tall or too wide. But other things to kind of assess for is, are they there at all? Okay, where are they in association to, say, the QRS, for example? And then you want to look at the QRSs. Are the QRS complexes narrow? So remember, normal is supposed to be less than 0.1 seconds. Often assessing, assessing it about 0.12. So we usually say, if it's the QRS is less than 0.12, it's normal. Or if it's wide, we'll call it QRS wide if it's greater than 0.12 seconds in duration. Understand there's a sort of a gray area between 0.1 seconds and 0.12 seconds, and we'll talk about that when that comes up. So what is the relationship between the P waves and the QRS complexes? So keeping in mind that the P wave should come before every QRS, all right, and a QRS should follow every P wave. Now that sounds like it should just be, make a lot of sense, however, there are times when you can see a P wave and there is no QRS or anything that follows it. Other times you may see a QRS where there's no P wave preceding it, and that's not a normal rhythm. And we'll give you examples of that. And then finally, if probably the biggest question is the rhythm regular or irregular? And again, that's going to take looking at that rhythm strip and looking to see if every time these complexes are formed, are they formed at regular intervals or not? Do the P waves all come out at the same, in the same intervals? Are the QRSs all in the same intervals, and so on? So if we have something that's totally normal, like let's take lead 1 for example down here in the cartoon. You have looks like 3 beats there, and you can see that there's a P wave before every single QRS. The P wave looks normal. Okay, it's of normal height, looks like it's normal duration. The QRS is following it. The QRS is nice and narrow. Okay, so we have a nice narrow QRS complex. And you can see that there's a P before every QRS and a QRS after every single P. And you'll notice that it looks very regular. The rhythm looks very regular. So this is normal rhythm. If we have arrhythmias of sinus origin, so let's start with that. So this is going back to those basic types of arrhythmias. So starting with the first one, sinus origin from the SA node, we could have sinus tachycardia. So again, tachycardia, this would be during someone who has a heart rate greater than 100 beats per minute at rest, for example. And you can see that as our example over here. Let me get my pen out. So this in A, this is sinus tachycardia. The rhythm is very, very regular. Those intervals are regular. You can see the P waves over here. All right, here's an R wave and then a T wave. So that's our complex there. And this is just a very fast rhythm, sinus tach. And if we wanted to calculate that heart rhythm, we could use that practice that we learned from the prior videos on how to calculate that by counting the number of large boxes between the R to R's, the R to R intervals. So here's one R, which is almost on our line there, which makes it a little bit easier. And there's another R over there, and you can see that there's about 1, 2, there's less than 3 boxes there. So if you remember our countdown method, 1 box is 300, 150, and 3 boxes would be about 100. This is less than 3 boxes. So this is greater than 100 beats per minute, so it's definitely tachycardic. If we take a look at B looks like sinus bradycardia. You can see the difference when you compare the tachycardia to the bradycardia. Here are our complexes. And again, you can calculate the heart rate for yourselves. Just count the number of large boxes. Okay. And again, count the number of large boxes. So you take 300 divided by number of boxes. These would be large boxes. Okay. And that would give you what the approximation of what that is. Or you could do the countdown method, which is what we just did for the tachycardia. So that's sinus bradycardia. Then there is something called sinus arrest, where the sinus atrial node stops firing. So this could be what we call asystole. Okay, so it just altogether stops firing. So the heart essentially stops beating for a time period. Recalling that the SA node drives the rhythm of the heart and the rate of the heart. If it stops firing, if you recall from my previous video, the SA node over here, I'm going to show you on the cartoon over here, that's the SA node, and there's the AV node. And I told you guys that the SA node fires automatically, and it keeps the pace because it fires the fastest. However, if it were to stop firing, the AV node, the bundle and the bundle branches, the bundle of hits and the bundle branches, they can also fire automatically. And the AV node is usually the most common site for that. So the tissues around the AV node would then fire and would take over the rhythm, if you will. And so what that means here is that we have our sinus arrest. We go to an asystole, and then we can have what we call an escape beat. And the escape beat is coming from, say, the AV node or the bundle or the bundle branches. And what it's doing is it's essentially taking over the rhythm of the heart because the SA node is no longer firing. So it takes over at its particular rate. So if the AV node in this example were to take over, it's going to beat it somewhere between 45 and 50 beats per minute. And so you can see here, we have 3 beats. Take a look at the example over here. All right, you have 3 regular beats, and then there's this long pause right here. Okay, there's a long pause. And so that's our asystole there. The SA node had stopped firing, and then you'll notice this complex right here. And something you'll notice about it is if you're paying attention, you'll see that there's no P wave, or at least you don't see any P wave preceding that QRS. The QRS is nice and narrow, and it's got its T wave, so it's repolarized. Okay, but there's no P wave. Now, the reason there's no P wave is because the SA node didn't generate this beat. This most likely came from the AV node. So usually what happens with an escape beat is there's a long pause before it of usually several seconds. Okay, so you have a several second pause, and then the AV node takes over. And there's no P wave because the AV node is generating it. The AV node, when it fires, it will send conduction backwards or retrograde towards the SA node. Okay, but it will also send the signal towards the ventricles as well. And so usually the P wave is lost somewhere at the same time as the QRS is going on. So that's why we don't see a P wave. So again, no P wave with a narrow QRS means that it's probably the AV node, and the QRS looks basically like the rest of the QRSs. So we call that a junctional escape rhythm. Escape because it's escaping from the long pause. Okay. And it's junctional because it's right at the AV node junction. Unfortunately down here is a little bit blocked by the video, but this one would also show another pause. You have 3 regular beats and then another long pause. And what you'll notice in this example is that the QRS does not look like the same QRS that you saw from the other ones. This QRS is kind of wide. It's widened. It's greater than 0.12 seconds. And so therefore it's not junctional, because if it were junctional, the QRS would look exactly the same because it's following the same electrical pattern from the AV node to the bundle and so on. But this one does not look like that. There's no P wave, so it's not coming from the SA node. There's a pause. So this is an escape beat, but because it looks all kind of wonky, this is usually coming from an area that's not part of the normal conduction system. So for example, the ventricles. So the ventricular myocytes, okay, if they were to fire or create this escape beat, you would end up with a wider looking QRS. And again, because it's not following the quick normal pattern where they make it a more, a narrow QRS with, less of a duration. And then finally, the last bullet I have, there's a respiratory sinus arrhythmia. And this is fairly common, and often just benign. But what you'll see is that there's sort of this irregular pattern to it, where you'll notice that every time the patient breathes in, there's a cluster of complexes that are suddenly faster. So the heart rate goes up when they breathe in and goes down when they breathe out. And so this is what we call it, a respiratory arrhythmia. So they breathe in, speeds up, breathe out, it slows down, and you can kind of notice that pattern where there'll be sort of clusters of area where it picks up speed and then it slows down again and it picks up speed. And you'll notice that if it correlates with their breathing, then that's what you have. Ectopic rhythms. These are rhythms that arise from somewhere other than the sinus node, as I mentioned earlier, and usually has a quicker depolarization than the sinus cells. Now, oftentimes this is abnormal because this is coming from cells that might have been ischemic or injured for some reason, like the ventricular or atrial myocytes, and outside of the normal conduction pathways. And these are different from escape beats, because escape beats come when there's a long pause when the SA node has stopped firing. So here, the ectopic rhythms tend to insert themselves sort of at random times. And so let's take this example here. So I'm going to draw the arrow there. So what you notice here is we have a regular complexes, but then we get to this one right here. And you'll notice that the P wave is somewhat inverted there. All right, so it doesn't look like the rest of the P waves. All right, so this complex here is actually our abnormal complex. The QRS is still narrow. It looks and repolarizes similar to what we see with the other complexes, but that P wave is upside down. And what that suggests is that we have some sort of ectopic atrial myocyte that's firing, and it's sending it retrograde, possibly towards the SA node, which is flipping it upside down. And you'll notice it kind of just plops right in there. There was no pause that came before it, but usually what you'll see is a very small pause or delay afterwards, because the SA node has to kind of reset itself. And then there's a little pause after the fact, and then we kind of go back to our regular, and you can see we're going to kind of go back into our regular rhythms there. Now over here, all right, same idea. It's ectopic, but you'll notice we have our regular complexes, all right? But then as this one is sort of repolarizing, this is where the T wave is supposed to be. Right after the T wave, you notice this guy. And so this is a very odd looking shape. It's very wide. And this is actually an ectopic beat from ventricular myocytes. And as I kind of alluded to it on the previous slide, if the ventricular myocyte is to, fire off a beat beforehand and it's not following the normal conduction pathways, it gives you these wonky looking waves with QRSs that are wide. And so this QRS does not look like the rest of the QRSs. And so this is an ectopic ventricular beat. And it sort of inserted itself almost immediately after the T wave there. Whereas the complexes before, you'll notice there's a little bit, of a gap between the next complex. It had a nice regular rhythm to it. But then this guy here just inserted himself right there, and that's an ectopic. So it's not an escape, it's just an ectopic beat. And you notice a little bit of a pause after the fact, and we resume normal activity. Now, in reentrant rhythms, this is what I was describing before, where you have this disorder of impulse transmission, and you end up with, sometimes a small focus of abnormal electrical activity, but it could also be many foci, or even large areas of the heart. So what the cartoon over here is just demonstrating is that, imagine that you have our normal sort of conduction pathways going through the heart, from the SA node to the AV node and through all the electrical channels that it normally takes. And as it sort of spreads its way through the heart, you're going to get different pathways, like A and B, for example. Let me just change the color of it here. But here's A and here's B. And what the arrows are depicting are depolarization. And you notice if I have, this particular pathway, this, A is going towards to the left over here, B is heading over towards the right. And as they're conducting at essentially similar velocity. Okay, and they're depolarizing all of the resting myocytes that are in front of them, all the myocytes that have been reset. So the depolarization wave is moving in one direction. It's not moving backwards, because everything that it's already depolarized is now in what we call a refractory period, and so they're not able to be excited again. And if these two waves, A and B, were to come meet each other at this point here, they would not go up the circles and around again, because all those cells would already be refractory, because they've already been excited. And instead, that would actually just push, the pathway in the unidirection in that way, because this tissue down here has yet to be excited and will start to fire and so on. And so that's typically what happens. Okay. Now in 2, let's just say, for example, where on pathway B you see this little black line there, which represents some type of slowed conduction, either damaged tissue, or the myocytes not responding exactly appropriately. They're not going to respond with their action potentials with the same velocity. And so A is going down its normal path, but B has been slowed down by this abnormal tissue that's there. And so that gives A a chance to actually excite some of the tissues that B was supposed to. It'll also continue down its normal path as well. So it kind of goes backwards. Now in some cases it's no big deal, because as it goes backwards and meets that slow tissue that B is already excited, nothing happens, it stops there. Okay. On the other hand, sometimes what happens is, in that slowly conducting tissue there, it may actually repolarize fast enough where, as A is making its way back around again towards that black line, it may repolarize by the time A gets there. And if that happens, it could actually excite that tissue over again. So here we see A going around, and then it continues to go around because the tissue behind it is no longer refractory. And so you have this sort of electrical racetrack that's occurring, because under normal circumstances, everything has depolarized together and is refractory at the same time. But since a portion of B had become somewhat abnormal, now it changes maybe the length of its action potentials. And so it might actually not be refractory anymore, and A has had a chance to actually circle around, excite that tissue, and then re-excite the tissue that B had already excited previously. And so what ends up happening is, as long as the timing is right and everything is ready to be depolarized again, it'll continue to kind of loop around in this electrical racetrack, if you will, almost indefinitely, essentially. Okay. Now, what you're seeing here in this lead over here, in lead 2, is you'll notice a very fast rhythm. So it's tachycardic, very, very regular. Okay, and this can occur. You can get this kind of tachycardia where the beats are occurring very, very quickly, but it's a very, very regular rhythm. So it's kind of going around that racetrack at a very regular intervals, but it's creating high speeds, high heart rates. We refer to this as a re-entry loop. Now, if we look at a re-entry loop, they can occur in the atria, in the nodes like the AV node. It can occur in the ventricles. And it would look slightly different on each of the ECGs. So if we take a look at reentrant atrial arrhythmias first, one of the most common ones you can see are something called a paroxysmal supraventricular tachycardia, or a PSVT. And this can happen in normal, healthy hearts from, say, overstimulation, too much alcohol or caffeine, too much stress. You can start to feel what they call palpitations. And, this could be because somebody has PSVT. It's very regular rhythm. Okay, so reentrant loops is that cycle. The rate is somewhere between, the atrial rate is somewhere between 150 to 250 beats per minute. Okay, so that's driving the heart rate, to about 150 to 250 beats per minute. And it's driven by a reentrant circuit loop typically located in the AV node. So that's actually important for us clinically, and I'll explain that. So this loop, this electrical racetrack, is located in the AV node. And if it's located in the AV node, what that means is that we can actually physically do something about that, because we could actually terminate this particular loop by doing what they call a carotid massage. So you see here, the carotid massage. You do a carotid massage. You could do a Valsalva maneuver. If those don't work, you could do, or you could use something called adenosine, which actually blocks the AV node and basically inhibits AV nodal activity, and also inhibits any more action potentials firing in that loop, so it can terminate it. The carotid massage, again, what you're doing is you're basically tricking the heart by massaging the baroreceptors at the angle of the jaw there. And if you were to actually do the massage or put pressure on it, that causes a signal to the brain to actually slow the heart rate down, because you're basically telling, by putting pressure on the carotid body there, it gives the impression that blood pressure has risen. And to help with that, to slow the heart rate down, it decreases sympathetic output and increases parasympathetic and so on, slows the heart rate down by inhibiting the AV node, for example. So it can inhibit the AV node, and that can actually break this particular cycle. So this is actually helpful, because if, PSVT can be mistaken for other rhythms, which I'll explain. But you could actually clinically, especially in a young patient, you could do a carotid massage, and you could see that you'll break the rhythm and get them out of it, or at least slow the heart rate down temporarily. And if you need to, you can use adenosine, which can also do the trick. And so clinically, we could also determine if that was PSVT based on, carotid massage maneuver. Atrial flutter. So atrial flutter is a very regular rhythm, but it's much more rapid. So the atrial rate is about 250 to 350 beats per minute. So it's quicker than PSVT. The reentrant circuit here, though, typically, not always, but typically circles around the tricuspid valve. So this loop goes around the tricuspid valve. And what it does is it creates what we call a sawtooth appearance in some of the leads. Oftentimes you'll see it in leads like 2, 3, AVF, sometimes I think in V1 as well. And you can see that down here in the ECG example, where here are the R waves, which occur at, which you can see over here, and then you see down here the baseline, you're seeing these undulating waves there, which kind of look tooth-like. All right, so the baseline kind of looks tooth-like or jagged, and they often refer to that as sawtooth appearance. And in fact, oftentimes they'll refer to it as a 3-to-1 or a 5-to-1 block. What that really is suggesting is this: the atrial rate is so fast, like 250 to 350 beats per minute, that not all the impulses coming from the atria trigger the AV node, because the AV node is too slow, it's still behind. So what ends up happening is it bombards the AV node with a lot of electrical activity, and the AV node only lets some of them go through. So in this example, if we take a look at the earlier parts here, let me use a different color, blue here. If I count the troughs over here, so 1, 2, 3, and then there's an R wave. All right, so that's why we call it 3-to-1. Over here, you can count the same thing. Here's a 1, 2, 3, and then an R wave. That's again, it's our 3-to-1. So 1, 2, 3, R wave. So this is called a 3-to-1 block. So 3 impulses for one that's going through the AV node. If we take a look over here, though, you'll notice that we have 1, 2, 3, 4, 5, and again 1, 2, 3, 4, 5, another R wave. So it went from a 3-to-1 block to a 5-to-1 block. The reason that happened is, let's say I couldn't figure out if this was, atrial flutter versus, say, the PSVT that I just talked about. If I do a carotid massage, which, by the way, is labeled right here, if I do a carotid massage will break the PSVT and stop it, but it will not terminate atrial flutter. Instead, what happens is, since you're inhibiting the AV node, it increases the amount of signaling that doesn't get through. And so you see that as an increase in the number of P waves that don't conduct through the AV node. So it can go from a 2-to-1 block or a 3-to-1 block to a 5-to-1 block in this example. In atrial fibrillation, this is where we have multiple re-entry circuits that just kind of whirl around. So this, again, like having these little electrical racetracks that are located not in one particular site, but essentially all over the atria. And oftentimes, usually found more often in the left atrium, by where the pulmonary veins enter into the left atrium. And so we'll see, a lot of different re-entry circuits there. And they can kind of move about in unpredictable fashion, so in different directions, counterclockwise, clockwise, and so on. And so you can't really see any real P waves because of all this activity. And so the rhythm is referred to as irregular, and it's oftentimes clinically assessed as irregularly irregular, especially when you're taking a pulse, for instance. And that rate is even higher. That can be 350 to 500 beats per minute. And essentially, if you take a look at the baseline just looks like it's fibrillating or just kind of undulating here, which you can see over here, where you can't really discern any clear P waves at all. And that can bombard the AV node. And in some cases, what you can have is a ventricular rhythm that's very slow. In this case, in A, you can see the R waves here. They're irregular. The baseline is irregular. So this is an irregular rhythm. And that's the classic AFib sort of appearance. At the same time, you'll notice that the rhythm of the ventricle is very slow in this case. Whereas in B, you can't really make out a good fibrillating baseline because the ventricular rhythm is very fast. This person's tachycardic, and you see all these R waves, you see all these waves over here, all right, indicating, it would be more like S waves, excuse me. But you can see that they are very, very quick. And you'll notice, that you can't really make out much of the undulating baseline. However, if you were to look at the rhythm of it, the rhythm is very irregular. And so that's, a good clue there. If you were to do a carotid massage here, you may slow down the ventricular rhythm, but you wouldn't terminate this rhythm. For the ventricular arrhythmias, all right, so we just talked about some of the atrial ones. There's some we call premature ventricular contractions, or PVCs, and I've kind of already talked about these actually when I talked about ectopic beats coming from the ventricles that give you these wide QRSs. Oftentimes those are referred to as a premature ventricular contraction, or a PVC. Then there's ventricular tachycardia, fibrillation, and something called torsade de pointe, which just means twisting of the points, which is a subtype actually of ventricular tachycardia. Now, PVCs, these premature ventricular contractions, are the most common ventricular arrhythmia, and oftentimes may actually be completely benign finding, actually, but the QRS is wide. It's greater than 0.12 seconds, all right, usually bizarre looking. But the dangers of these is that it could trigger VTAC or VFib, okay, which I have as VT or VF. And it can alternate with normal beats as ectopic beats do. And so here, you'll notice here's some of our regular rhythms, and then there's this guy here. And that right there is a PVC, or ventricular, or an ectopic ventricular beat, really. And then you got a little bit longer of a pause, and we go back to our regular beats again. Over here in B, again, we have what our normal complexes for this particular person, but then you're seeing these. All right. So these are the PVCs. Okay. Now, they may label them as, bigeminy or trigeminy. So for example, if you have a normal beat in B, so B over here, if you have a normal beat, then an abnormal, a normal, and abnormal, it's referred to as bigeminy. In A, if you have two normal beats and then an abnormal, it's called trigeminy, and so on. Now, the thing is, the PVCs, they can be malignant, and so sort of the rules of the malignancy are, whether or not it's frequent. So frequency matters. If you get 3 or more in a row, so if you have PVC after PVC after PVC, so if you get 3 of those in a row, that could be a short run of what we call VTAC at that point. Now, multiform just means like compare the shapes or what they look like, the morphology of them from one PVC to another. So let's take B for example. B, if you look at all of the PVCs, all 3 of those that you can see, all those PVCs look the same. So it has the same morphology. That's actually suggests it has more positive prognosis, for example. But if every PVC looked different, that suggests that that this is coming from multiple different sites, not the same site. So if it all looks the same, it's probably the same site. Multiple sites means there's probably multiple tissues that's damaged, or multiple ventricular myocardial areas that are ischemic or injured. And so multiform is not a good sign. And then there's something called depolarization falling on a T wave. So for example, if this PVC falls on a T wave, or in other words, if it occurs during repolarization of a normal complex, and the danger of that is that it can actually set up the person for a fatal arrhythmia, like VTAC or ventricular fibrillation. And we'll kind of talk more to that in some of the other examples, but this ectopic beat could occur. Typically, if it's going to occur on a T wave, it's usually if the QT interval has been prolonged. So the longer the QT interval, the higher the risk that something like an ectopic beat could actually occur at the same time as a T wave and cause the person to go into VTAC or VFib. And again, if you're seeing a lot of PVCs in the setting of somebody who just had a myocardial infarction or a heart attack, it's usually also a poor sign of damaged tissue. So ventricular tachycardia, this is where we have essentially a run of 3 or more PVCs, where we're essentially having more of a sustained VTAC as opposed to an unsustained VTAC. And the ventricular beats somewhere between 120 to 200 beats per minute. The ventricular myocardium usually can't depolarize and repolarize as fast as the atria, so we don't usually see beats as high as that. But it is concerning to have ventricular tachycardia or VTAC, because this is what's generating most of the force to actually propel blood out of the heart into systemic or pulmonary circulation. So this is why I categorize this as an emergency. And you can see down here, all right, this sort of sinusoidal pattern almost, and this is really this is sort of the classic picture of VTAC here. Now, however, VTAC in certain circumstances can look a lot like a PSVT in some cases. However, in VTAC, you'd have you'd have somebody usually has a heart that's a good bit sicker, whereas in PSVT can happen in younger healthy people. And clinically, the patient, a younger patient with a PSVT would respond to a carotid massage, whereas in VTAC they would not. Plus in VTAC it could change cardiac output and stability and so on. And so there are other clues within context that could help us discern the two. Now in ventricular fibrillation, so this typically occurs in dying hearts. So these are very sick hearts. This could be one of the reasons for sudden death. There's no true QRS complexes. There's no cardiac output. The patient's not responsive. And you can see here, over here, at least initially, this person was in VTAC, it looks like. And then the VTAC, at this point right around here, turned into VFib, where it's just defibrillating and the heart's not really moving blood effectively at all anymore, and that's why the cardiac output is dropped. in torsades, or twisting of the points here. This is a unique form of VTAC, and it's usually seen in patients who have a prolonged QT interval. So I've talked about how to measure QT intervals in a prior video. An example of that, which I have in parentheses there, is LQTS, which is just long QT syndrome, which can also be inherited. But QT intervals can be prolonged because of certain medications, for example, like antibiotics or antidepressants. And what happens is, with a longer QT interval, if they have a PVC, the PVC could actually then occur at the same time as repolarization is occurring, and so we call that a PVC on a T wave. And if you see this occur on a T wave, what can happen is they can go into either a short run or a prolonged run of VTAC. And the VTAC has a very characteristic look to it. So you can see down here, you can see this sort of sinusoidal waveform where it's large amplitude and then little amplitude and then large amplitude again. And it almost looks like it's twisting. And so that's why they call it twisting of the points. It's very characteristic. So I would refer to that as torsades. And it has a unique way in which we would treat it. So let's just try a quick case. So we have a man who's on tricyclic antidepressants and erythromycin, which is an antibiotic, both of which are known to prolong the QT interval. So he was already on the antidepressants. He went to the hospital for infection. They gave him erythromycin, and he was on the combination of the two now. And so here in A, okay, so we take a look at A. Let's take a look if we can find his normal. So here's a normal. These look like some of his normal beats. Maybe right here, all right, over here and over here. And then if we take a look over here, we have some abnormal, or PVCs. So it looks like you can see the waveform looks a little bit wonky there. The QRS is widened. It doesn't look like his other typical QRSs in that lead. They're kind of inserting themselves at random points there. And you'll notice right about here, so here's after his normal, at this point here on his third beat in the middle of his T wave, he ends up with another PVC. The PVC fell on the T wave. And so what you're seeing is this was a short run of VTAC. So you got a little run of VTAC, but then he kind of came out of it. Okay, came out of it. But then what we're seeing in B here, again, if we take a look for his normal, so here's, let's use the red again. Here's his normal, another one normal for him, and one right here. All right. Here's a PVC, and then here's another PVC. All right, and then you can see here's another one, and then here. So you can see that first off, these PVCs have different shapes to them. They don't all look the same. So this is multiform. Seems like it's happening frequently. These are all malignant signs. And you'll notice that on this, by his third beat over here, his third normal beat, on that T wave, he had another PVC fall there. And so the PVC occurred at the time it was repolarizing, and you can see over here, now he went into a torsades. If this were a little bit longer, you could see a little bit more clearly, but this is a larger amplitude in the beginning and a smaller amplitude down there. So he went into a torsade.